Hello everyone. I'm going to present an interesting case. It was done as an emergency procedure. This patient had undergone laparoscopic Nissen's fundoplication, and following which patient developed acute pain in the abdomen and severe vomiting. So after a third post-operative day, the patient was referred to our hospital for further evaluation and management. The original procedure was done at an outside hospital. So we did investigation and we found the stomach was lying inside the chest cavity. And after resuscitation, we took up the case for an emergency laparoscopic procedure. After introducing the ports, we could see the stomach, almost whole of the stomach has gone into the chest, and the opening was very tight. So we were trying to pull the stomach by using bowel graspers, but we could not be able to bring the stomach from the chest cavity into the abdomen. So we are making initial attempts to reduce the content, and since it was very tight, we are enlarging the opening by using harmonic scalpel, and even after opening the diaphragm, we are not able to bring the stomach into the abdominal cavity. The reason is the lung is densely stuck to the stomach. Initially we thought could be a gangrenous part of stomach. This is the lung which is coming out, that was holding the stomach inside the chest. It was not allowing the stomach to get reduced. There was a dense adhesion between the lung, which is collapsed now, and the stomach. So we had a confusion. We thought we are dealing with a gangrenous stomach, but after some times we realized that it is the lung which is adherent to the stomach. So we are extending the incision slightly more and wider in order to separate the lung from the attached stomach. You can appreciate the lung is not allowing the stomach to get reduced into the abdominal cavity. We are actually now undoing the 360-degree wrap, and we are trying to separate the stomach from the lung carefully. So you can see the lung is being peeled off from the stomach, and we are trying to push it inside the chest wall. But even then the part of the lung was not going back into the chest cavity. So that is again because of further adhesions of the lung to the posterior wall of the stomach. So carefully we are separating the lung all around so that it will be totally freed. You can see the amount of dense adhesions between the stomach as well as the lung. Then we went behind the stomach. We lifted the stomach anteriorly, and the lung was stuck to the diaphragm and the crura. The adherent lung is separated from the diaphragm and the posterior wall of stomach. So that is you can see it is adherent to the spleen also. Actually part of the spleen was also inside the chest cavity, which was reduced, and the lung was adherent to the spleen also. So all the adhesions were carefully freed and the lung was pushed inside the pleural cavity. And we are assessing the defect, and we are introducing the telescope into the pleural cavity on the left side. This is the left side pleural cavity, and we are introducing the intercostal drain under laparoscopic guidance. And by using the bobbed suture, we are narrowing the diaphragmatic opening carefully. Normally for diaphragmatic hernia, we used to place MS, but here we are not placing MS because of the field, which is not very comfortable to place MS. So we are taking carefully to approximate the divided diaphragm. These are all the divided part of the diaphragm, and further medially it is the defect which is causing the diaphragmatic hernia. This could be an iatrogenic hernia. Normally the stomach or the wrap will move into the mediastinum, not into the pleural cavity. There may be an associated diaphragmatic injury with pleural injury, parietal pleural injury. That's why the stomach has migrated into the chest cavity. So we are closing the defect in the diaphragm. We prefer to put few knots to even to the bobbed sutures so that it will be more secure. This is a PBT suture. The size is number 1. Then we are lifting the esophagus anteriorly and we are going to do the crural closure. That is the crural closure step. You can see the caudate lobe is very close. So we have put 1 or 2 sutures to the crura behind the esophagus so that it will not be abnormally wide. And after again we are assessing the defect size, and we thought we can put 1 more stitch to the diaphragm so that we can prevent further herniation. In this case, we didn't do a fundoplication. Patient is under follow-up and is doing very well. The tissues are not very healthy. That's why we have not done any fundal wrap. And you can see there is adequate gap between the crura and the esophagus for the food bolus to come down. The traction by using umbilical tape at the OG junction is very useful to give the exposure, and we have completed the procedure and checking for hemostasis and this stomach wall if for any injury. And there is no injury to the stomach wall. And this is a closure of the diaphragm. All looks okay. And we are placing a drain into the abdominal cavity as well. With this step, we are completing the procedure. Thank you very much.